Thank you, Deb, and thank you to the rest of the program committee for putting on such a great program and asking me to be involved. As you mentioned, I'll be talking about our post-market experience with Cenegermin for the treatment of neurotrophic keratopathy keratitis. These are my financial disclosures, none of which are relevant to the contents of this talk. All right, so Cenegermin is a topical preparation of recombinant human nerve growth factor. It's gotten, there's quite a bit of excitement about this. It's a fairly new medication, and it's made its way through the various regulatory pathways quite quickly. Because of the relative rarity of NK and the lack of novel treatment options that are available, it was given orphan drug status in the United States by the FDA back in 2014, and it did receive its approval for the treatment of neurotrophic keratitis in patients ages 2 and up by the FDA in August of 2018. Prior to that, it did receive CE approval in Europe, and that was in July of 2017. And it was eventually released to the United States market by Dompe in early 2019. I believe it was in January of 2019, under the trade name Oxervate. It's currently supplied in multi-use daily preservative-free vials. And the way it's set up right now is the medication is shipped directly to the patient 1 week at a time from a Credo specialty pharmacy. It's dosed 6 times a day, and the treatment course is 8 weeks. And it is an expensive medication. Not surprising, but it is quite expensive. The cost of the treatment is nearly $100,000. Now, patients aren't, typically paying for this out of pocket, and in our experience, the insurance coverage has been quite good. There were 2 pivotal trials that led to the approval of this medication. As mentioned earlier, the first one was conducted in Europe. It was a multi-center trial. It was known as the Reparo trial. And this was a randomized trial where patients with either stage 2 or stage 3 neurotrophic keratitis were divided into 3 different arms. The 2 arms that received treatment received Cenegermin at either 10 micrograms per ml or 20 micrograms per ml. And then there was a third arm that received the vehicle. The eventual dose that was approved and that was commercialized was the 20 micrograms per ml dose. Primary endpoints in this trial were corneal healing at the 4-week mark, and the secondary endpoint was corneal healing at the 8-week mark. So at the 4-week mark, in the treatment group that received the 20 milligram per ml dose, 58% of patients had complete healing of their epithelial defect versus 14% in the control group. At the conclusion of treatment at the 8-week mark, 72% of patients had complete healing versus 33% in the control group. There was a total follow-up period of 48 weeks in this study, and at the end of that, 3.4% of patients had an epithelial defect that did recur. And as far as adverse events go, the most common was eye pain, and that was present in 8% of patients. Subsequently, there was a very similar trial conducted in the United States, again, multi-center. This was 2-armed with just the 20 microgram per ml dose as the treatment dose versus vehicle, and very similar results. At 4 weeks, 57% of patients in the treatment group had complete healing versus 21% in the control group. And at 8 weeks, that went up to 65% of patients that were treated with the active medication had complete healing versus 17% in the control group. And again, eye pain was the most common adverse event, and in this group, or in this study, that was at 12%. So, my task for this talk was to discuss the post-market experience. So in preparation for that, I did a literature search, and interesting enough, there's not much out there on this. In fact, there are just 2 case reports. One describes the potential adverse event of an epithelial plaque formation during treatment with Oxervate that subsequently resolved after discontinuing the medication. And then the second one was a case report that came out of Italy describing the use for this in pediatric patients, in a patient that was 3 years old. Now, interesting enough, this medication does have FDA approval in children 2 and up. Neither of the pivotal trials looked at children, however. So this was one piece of literature that was published with results in children. But beyond that, there really isn't much out there. So what I decided to do was to look at our own experience at Wills Eye Hospital with the use of this medication. So since its approval, or since its availability in January of 2019, we did prescribe this to 21 patients. And of those 21, 18 patients were able to fill it. 3 had denials by their insurance company. Now, we did have some suspicion about this, and we did feel like this was a little bit of an issue, but going back and looking at the data, we noticed there was a pretty significant lag from when we sent the order in to when the patient actually started the medication. And there was a mean of 41.6 days for that time period, and the range was 6 days to 97 days. And each individual patient is plotted on that graph on the right. And that very first, and I apologize, the formatting's a little off. That should say, December 2018. That was the very first patient I prescribed this to, and the patient got the medication in 6 days. So I was super excited about that. I thought, this is great. This is a highly efficient process. But over time, that has been quite variable. So there is a little bit of lag time from when we write the prescription to when the patients actually get it and start it. As far as the patients that we have treated with this, 10 were female, 8 were male. The average age was 57 years old, but we did have a range from 4 to age 88, but the predominant patient group was between the age of about 40 to 80. And all of these patients did fail to improve with conventional treatment, whatever that was, whether it was bandaged soft contact lenses, self-retaining amniotic membrane, serum, tears, or torsorrhaphy. All these patients failed to improve, and as a result, we decided to start them on Oxervate. The pivotal trials looked at stage 2 and stage 3 only, and those were the majority of our patients, but we also prescribed this to 4 patients with stage 1 disease. And we were a little concerned about, would the insurance company approve this? But so far, our experience has been okay, and we have been successful to get this medication, even in patients with stage 1 disease. As far as underlying neuropathic etiology, it mimicked what was seen in the pivotal trials. About half of patients had either herpes simplex or herpes zoster. We had a few patients that had an underlying condition like herpes simplex or aniridia, and then subsequently went on to have a full-thickness corneal transplant. After the corneal transplant, they then developed a non-healing epithelial defect. And then we had a scattering of patients that had prior surgery and, as a result, had subsequent neurotrophic keratopathy, for example, diode cyclophotocoagulation for glaucoma, trigeminal ablation for herpetic neuralgia, orbital radiation for the treatment of an orbital tumor. There was 1 patient that had stage 1 disease following LASIK, and 2 patients that had extensive retinal surgery that went on to develop neurotrophic keratopathy. As far as our results go, they were quite good, at least we thought so. Of the 4 patients that we treated with NK stage 1, all 4 had improved corneal staining and subjective improvement in their symptoms, and that was predominantly vision. In the NK type 2 group, 7 of the 8 patients had closure of their epithelial defect. The 1 patient that did not was the one that had extensive orbital radiation, and she has remained unhealed despite 2 sutured amniotic membranes and a permanent torsorrhaphy. And then the NK stage 3 group, all 6 patients in that group also had their epithelium closed. Our average follow-up, it's not the longest. On average, it was 88 days with a range of 1 day to 186 days. Other things that we noticed when looking at our data, the trials discussed that, around 10% of patients had pain. Our experience was it was a little bit more frequent and maybe more severe. 5 out of our 18 patients complained of severe pain. 2 were forced to decrease their dosing frequency. 1 patient had to take a week off of work because it was quite debilitating, and this was a younger individual that was still in the workforce. All patients, however, were able to complete the course in its entirety. As far as recurrence of an epithelial defect, we did have 1 patient that did have a new epithelial defect 64 days after their last Oxervate dose. And this next point was something that interests me quite a bit, is we had 1 patient that had neurotrophic keratopathy because of herpes simplex, was treated with oxyrvate. That defect closed but had a visually significant scar, and then subsequently went on to need a full-thickness corneal transplant. So, these are higher risk patients when it comes to penetrating keratoplasty. And, the hope is oxyrvate or Cenegermin will help with wound healing, help with reepithelialization, even after a corneal transplant. And after the surgery at last follow-up, 183 days later, this patient has still had healthy epithelium. Now, one thing to keep in mind with our results is this wasn't a controlled trial. So this was real-world treatment. And often what we do is, we don't just treat patients with Cenegermin. We have additional treatments going on at the same time. So, each patient was different, but 2 patients were also simultaneously getting serum tears. 5 patients received suture amniotic membrane with a temporary torsorrhaphy, and 3 patients had a torsorrhaphy alone. And, we'll go through a typical patient. So this is a patient that was, 79 years old, referred in with a history of herpes simplex 20 years prior, and was referred in for a corneal abrasion that was not healing after preservative-free tears, ointments, bandage contact lens. And that is the photograph that was taken by my partner, Dr. Chris Rapuano. He takes beautiful photos, so I always like to use his. And again, this is just the classic appearance of a patient with NK stage 2. And this is kind of what we do. So when we see these patients, we start the paperwork for oxyrvate, kind of knowing that the patient is not going to get it right away, and then we start other treatments. So this patient, for example, received 2 self-retaining amniotic membrane devices with no improvement. He was taken to the operating room, had a sutured AMT with a temporary torsorrhaphy, and then after that, about a month and a half later from when the prescription was written, the Cenegermin arrived in the mail, and the patient started it. So this was a patient's appearance 3 weeks following the AMT and 2 weeks into the Cenegermin treatment, and you can see the epithelial defect is starting to close. You can see a little bit of amniotic membrane remnant. And then 3 months after the course was complete, you can see closure of the epithelial defect with some mild residual corneal staining. So a summary of our experience, patients are having a longer than ideal time to get the medication from when we order it, so that is a little bit of an issue that we hope gets improved. Efficacy post-market is similar to what we see in the pivotal trials. We do, however, see more frequent complaints of pain, some of which can be quite severe. And our experience, at least, is to use Cenegermin in combination with other treatments like suture amniotic membrane and torsorrhaphy. Thank you.